Good afternoon, ladies and gentlemen. It is my great pleasure to join you on Gulf International Society meeting. I thank all the organizers for giving me this opportunity to present this case. So I'll be talking about unusual complication of left main PCI. I have no disclosures. This is a 73-year-old woman with the non-ST elevation MI who presented to our hospital. And as you can see by this echocardiogram, there is a significant LV valve motion abnormality in the anterior apical and infra-apical regions with an ejection fraction about 30%. And then the coronary angiogram that the patient has been taken to, you can see that she had a significant left main disease in the distal left main involving both ostial LAD and the circumflex, a Medina 111 bifurcation lesion in the left main with some calcification as well. So the further pictures, as you can see that there is some haziness in the mid to distal LAD, and that's probably from the calcification. And we decided to proceed with a PCI, given her comorbidities, which include diabetes, mild renal insufficiency, obesity, and as well as non-ST elevation MI. And in the setting of COVID, we have seen that we have been doing more high-risk PCIs as compared to prior, as the availability of hospital stay and CVICU beds for bypass surgery patients are limited. So hence, after having a heart team approach for this patient, a discussion was done, and we decided to proceed with PCI with the impeller guided of the left main in our cath lab. So as you can see in the picture on the right, that there is an impeller device that has been placed in the left ventricle without any comorbidities, without any difficulty. And there's a PA catheter that also has been placed to assess the pressures in the right heart pressures. And there are two wires that are placed, a run-through wire into the LAD and pro water and circumflex artery. And sequential dilatations of the ostial LAD and ostial circumflex and left main were performed. Pre-dilatation was successful. And then we proceeded to perform a nano crush, as you can see here, with the two stents. And we initially stented the circumflex. And we took a picture without before removing the wire. There was no dissection, and hence we removed the wire in the circumflex. And then we stented the LAD to left main successfully, crushing the circumflex stent. Just a small 0.5 millimeter to 1 millimeter stent was hanging into the left main from the circumflex. And following that, obviously, we, as you can see here, we are performing a post-dilatation, proximal optimization with the a 5O balloon, as the stent in the left main was 4.5 by 22 millimeter stent. And then we performed the part with the 5O balloon. So after part, as you can see, this was the report after final kissing balloon. And you can see that there is extensive dissection perforation of the left main into the aorta. So there's a dye that is hanging up into the aortic sinuses. And at this point of time, obviously, I was in the control room while my fellows were performing this PCI. Then I ran looking for a covered stent. We did not have a 5O covered stent. And so another 5O 12 millimeter onyx stent was available. So we just actually used another regular resolute onyx stent in left main. With that, actually, we were able to seal that perforation, and still some of the contrast is hanging in the aorta. At the time of perforation, I have to say that there was no pulsatility at all, and patient completely became dependent on the impeller. However, her mental status was very good. She was communicating with us, and she obviously had a huge pericardial effusion. So that was tapped using pericardiocentesis, and a pigtail was placed. And as you can see, this is the pigtail and the TE guidance. And the anesthesiologist was able to perform an immediate TE and an intubation as she became hypotensive. And so the stent was placed, and but whatever blood that has leaked prior to that stent placement resulted in the pericardial tamponade. So I wanted to highlight this case and also talk about the retrograde coronary dissection of perforation extending into the ascending thoracic aorta, which is a rare complication. The prevalence is 8 in 10,000 patients for diagnostic catheterization, and about 6 in 1,000 patients for PCI procedures. And 87% of them are in the right coronary artery and 13% are left main. And now in my particular patient, it is aggressive proximal optimization technique that has led to this left main artery perforation. The 5O balloon was inflated to 24 atmospheres, and I think that's what has caused this type of complication. So treatment strategy for left main dissection with extension into the aorta is very unclear: surgery, conservative, or stenting. And there has been several case reports that have been, and articles that support one versus the other. And this is another patient with a 70-year-old female, multiple risk factors, inferior non-ST elevation MI 3 months ago. PCI of the right coronary artery was done with bare metal stent 3 months ago. Now she had a class 2 angina pectoris, and she came into the hospital. Echo showed the ejection fraction 64%, and normokinesis of the left ventricle. And RCS stent is mild in-stent restenosis, mild disease in the proximal to the stent, but nothing in the, within the stent. And there is here LAD is the target lesion, and the left main had a 25% lesion, LAD had 70% stenosis. And so the successful stenting was performed, but however, there's a retrograde left main dissection with extension into the ascending aorta. As you can see, I don't have any pictures, cine angiogram pictures, but this is a nice photograph showing how extensive is aortic dissection. So what is the way to treat such patients? Surgery of the aorta and the CABG and is one option. Stenting, then making decision about the treatment of aortic dissection is the second option. I think here the choice was immediately placement of a stent at 3.523 millimeters in left main to LAD, and then post-dilatation with the 4.010 millimeters, again at 24 atmospheres. I think, in my opinion now, I think I would not actually go more than 18 atmospheres in this type of proximal optimization technique for most of these patients to limit the complication rates. So CT angiogram was performed 1 hour after stenting. There was no extension of the dissection into aorta, and the left main remained open, and hence there's no indication for surgery, and the patient was discharged in 7 days. And as you can see, the contrast medium leakage into the false lumen is visible here. So the treatment algorithm for iatrogenic aortic dissection, if it is less than 4 centimeters into the aorta, stent the coronary ostium immediately, and if it is successful, surveillance in ICU for 48 hours, or if unsuccessful stenting, consider bypass surgery or aortic surgery. If the dissection extends more than 4 centimeters into the aorta, and if the patient remains hemodynamically stable, stent the coronary ostium, and if unstable, proceed with the surgical management. I think this is very important in these patients. I don't think everyone has to go to surgery. So in conclusion, a conservative strategy, or in my opinion, a stenting strategy, may be useful in the case of left main dissection or perforation with extension into the aorta after urgent left main stent implantation. The most important thing is prevention. I think prevent aggressive proximal optimization technique to more than 18 atmospheres I would avoid from now on. That's the lesson that I've learned from this case. With that, I would love to stop here, and I would love to take any questions that you might have. Thank you very much.